So we've talked about the treatment plan, and I'm going to focus on the antibiotic active infection and prophylactic treatment. I am a child psychiatrist, though, so I'm it's interesting, I'm skipping over the psychotherapeutic. I don't know if anybody's going to talk on that, but usually I'm very conservative with my psychiatric medications. I use lower doses. I think Dr. Tienemann had mentioned that. And I tend to use medications that are more inert. And I'm a huge believer of cognitive behavioral therapy for children that are in partial remission after they've had their acute treatment. All right, good old Mac. All right. It's my fault. I put in a new one, so she didn't have a chance to fix it. So that's just all right. We can work around it. So we've heard about molecular mimicry, and that's very important. But one of the things I wanted to go over is that there's a lot of different ways these children can be triggered with their acute presentation. The infection comes in a lot of different presentations, from a sore throat to sinusitis, cough and pneumonia, dermatitis like impetigo, perianal and vulval vaginitis. And we've heard about some of the triggers, primarily so far Lyme and group A strep, but mycoplasma I think is also a big player. And viruses can be a big trigger, but a little bit more tricky to treat when you have those triggers. Strep throat is very contagious, and it can spread through families pretty rapidly, and I believe Dr. Schulman can support me or not on this, but I think sometimes back in the old days they would actually treat the whole family when one child would be sick, and I don't think pediatricians do that anymore. The main reason we treat it, it's a transient pathogen, but it can cause all the autoimmune sequelae that we've heard about today. Subclinical infections and chronic carrier states are a little hard to sort out for the average clinician. And so if I had a child that presented with acute PANDAS and had no symptoms of pharyngitis but had group A strep in their throat, I would absolutely treat it and would not worry if it was carrier or subclinical. This is a diagram one of the parents had created for me. And I like to use this because I think it demonstrates 2 points. A lot of the children that I've seen, typically around 7 or 8 years old, will have this huge explosive, PANS episode. But when I do their history, I often hear of what I call a micro episode, that it might have occurred when they were 3 or 4 years old. And for a lot of these children, it spontaneously remits, so they haven't come to clinical attention. Occasionally, they may have gotten on the antibiotic for something around that time, and that may have helped. But usually it does take about 6 to 8 weeks for the flare to improve on its own, and that's typically the course of usual antibodies half-life. The other thing I wanted to point out is that with Sydenham's chorea, we've heard that in the past that the strep infection may proceed by weeks before the clinical presentation Sydenham's chorea. And these children, they can sometimes present with their PANS PANDAS a day before they might present with their strep throat or their clinical pharyngitis. And so the time period for presentation and infection, I think, is a very short time, from days to a couple of weeks. Some of the observations I've had on flares is that a close exposure can drive the neuropsychiatric symptoms, and even in children on prophylactic antibiotics. Not all flares will be strep. I think we heard a little bit about, various things can cause flares. And a few treatment will get much better, will get better without much treatment, like especially that micro episode that I described. And I like to point out that I'm probably one of the few child psychiatrists that, their patient draws a doctor swabbing the throat. So I'm not going to go into extensive description of what you should do for every case, because I think a lot of the cases have variable presentations. But some of the stuff that I do for most patients is I do a complete blood count with a differential, and I look at either a SED rate or a CRP. Most of the children that I see are normal on these parameters. I sometimes will see neutropenia, which I think may be one of the reasons they're more inclined to present with PANDAS. A comprehensive metabolic trial, and this is mostly to make sure they don't have liver enzyme elevations, and especially if I'm going to be putting them on medications that may put their liver or kidneys at risk. Urinalysis, and this is because some present with the enuresis and frequent urination, but they're almost always normal. And then, of course, a throat culture, anti-streptolysin O and anti-DNase B. And if they have a history of a URI or a cough, then I check mycoplasma titers. And if they're currently still ill with a cough or respiratory symptoms, then I might check mycoplasma PCR. I do a vitamin D level, and I check an EKG, especially if I'm going to be using azithromycin. The strep antibodies, typically the ASO goes up first, and then the DNase B goes up. Usually the ASO is a little bit more specific for throat infections and DNase B more with skin infections, but you can see it with both. There's an age effect on titers, and the titers will naturally be higher in the 6 to 12-year-old age range. Unless you get sort of serial titers 4 to 6 weeks apart, you really don't get a good sense of the timing of what the titers may represent, because they can be elevated, and it could have been the infection was 3 to 6 months before. Preschool children may not show elevated titers because sometimes I think they need a certain amount of strep infections before they meet that threshold titer. And many clinicians will see no strep titers and say, oh, not PANDAS, they just got OCD. And so they won't even consider, maybe mycoplasma, or that they could be one of the 40% of children that won't mount a strep titer after acute strep infection. In our recent guidelines, we have what's considered adequate for a strep diagnosis, and this is the serial titers, a throat culture, suspicion of strep because somebody in the family or somebody close to the child had strep. They had a culture documented strep dermatitis, or they have a very high elevation of at least one of their titers, or an 80% elevation of 2 titers. And this would be considered adequate for making the diagnosis of PANDAS. Treatment, if you culture them and they have strep in their throat, then absolutely treat them even if they do not have clinical symptoms of pharyngitis. We usually try to stay with what's recommended mostly by the rheumatic fever guidelines for strep, which would be penicillin and amoxicillin. But some children don't have a full response to these 2 antibiotics, and then we move on to some of the other ones like the cephalosporins or azithromycin. I tend to lean more towards azithromycin when I think they may have mycoplasma, and I don't see a lot of Lyme in Florida, but certainly up here you would be a little bit more worried about that. And I use doxycycline occasionally when azithromycin hasn't worked for mycoplasma-triggered PANS. So when you know that they have had group A strep, or they meet one of these adequate criteria for group A strep, then obviously treat them with antibiotics. And then this is a part that maybe not everybody would agree with, but we did actually put this in our guidelines. If they have an acute severe onset of OCD, meets the PANS criteria, I go ahead and treat them with a course of antibiotics, and then give them about 3 weeks to see if there's any significant change. If they're changing dramatically after 3 weeks, I tend to continue the antibiotic until they're closer to remission. And then I'm always vigilant for, is strep running through the school, is strep running through the family, to make sure that they're not getting close exposures. These are the general treatments for group A strep pharyngitis. There's a lot of variations in the way that some of these medications taste, how they're administered, how frequently they're administered. And then, of course, if they're penicillin allergic, then you would want to use one that was in the right-hand category. But if they have intolerance or lack of improvement to penicillin or amoxicillin, these are some of the ones that we might use. Cephalexin would be an option if they're allergic to penicillin. Cefadroxil you could use, but avoid if they have an amoxicillin hypersensitivity. And this one probably has one of the least amount of effects on gut flora, and so I've been using this more recently with good success. Amoxicillin clavulanate is a good one, and had great success with it with PANDAS. And this would be particularly a good choice if they have problems with chronic sinusitis. Clavulanate may have a lot of other neurochemical properties, and so maybe that is the reason we're seeing some of the better benefits with it. Azithromycin, one of the problems is that there's some regional group A strep resistance, and so it's something to always take into consideration, especially if the child's not getting better. They may have a group A strep resistant bug. It acts against mycoplasma, as I mentioned, and it has a lot of immune modulatory properties, as Dr. Schulman had mentioned. And I've seen similar presentations where I take them off the azithromycin if I don't taper, and 3 days later they have a big flare-up. So I've always found this curious, and I don't know if it's immune modulating properties, effect on the microbiome, or if it's somehow antibacterial. You do see QT prolongation with this, so I would caution using it, especially if you have children on a lot of different medications. And I usually get an EKG at baseline and then while they're on the medication. Clindamycin is sometimes used. It doesn't have a very good taste, and it has an unfavorable impact on the gut flora. We looked at treatment response in the PANDAS survey, where 698 parents filled out surveys on their children presenting with PANDAS, and found that a lot of the antibiotics actually have some efficacy. Amoxicillin was one of the least efficacious, and this is all by parent report. And what about secondary prophylaxis? I think if the child has had a lot of problems with flare-ups, sometimes the flare-ups, I think Dr. Schulman sort of hinted at this, when you get 2 or 3 flare-ups, they don't always respond as well to antibiotics on the second, and third, and fourth flare-up. So if they have a lot of flare-ups, I definitely would put them on prophylactic antibiotics to maximize their long-term improvement. Usually we do this for at least a year, sometimes 2 years, and if they're really severe, then we might do it until they were 18 years old. In the PANDAS survey, we actually surveyed parents about the children that received the antibiotics for greater than 30 days. And azithromycin, augmentin, penicillin, and other cephalosporins were ones that they found very effective. I think we've hinted at this between Dr. Schulman and myself, that there's multiple effects of antimicrobials. First you want to make sure you're treating the infection and preventing the infection, but then they may have immune modulatory properties. And macrolides and cyclins have widespread interest due to their inflammatory properties. The doxycycline, minocycline actually have some impact on the blood-brain barrier, and they also downregulate inflammatory cytokines. Same for azithromycin, it has properties to decrease inflammatory cells and inflammatory markers. So I think these multiple effects make it an appealing treatment for neuropsychiatric symptoms triggered by infection. There's been a few trials of that are randomized clinical trials for using antibiotics in PANDAS. First 2 were done by Dr. Sweeto. The first one was confounded by some design issues, and the second one showed that prophylactic antibiotics decreased neuropsychiatric exacerbations. I did a Ceftonir study for children that weren't really meeting PANDAS criteria, and they had just had new onset OCD and tics, and we found clinically significant improvements, but it was a small study and there were no statistically significant differences between the groups. And then the azithromycin trial we did recently, looking, and it was double-blind, placebo-controlled, and all the children received probiotics. So in effect, all children had somewhat of an active treatment. And we found significant reduction in OCD severity, and this seemed to be moderated by those that had the highest tic severity, seemed to have the most improvement. We did see a 10-point increase in QTC interval from baseline to end of study. I don't know if I have a pointer, but one of the things that was interesting in the study when we mapped it out at the every 2-week interval is at the end of 2 weeks, there was no difference in response between the azithromycin and the placebo group. It was only after the 2-week mark that they started to separate in clinical improvement. And then we did an open label trial starting at end of week 4 and continued it to end of week 12 and saw gains in both groups. Wow, these slides are all over the place. So I think a proper diet is important. A lot of these children are food restricting, and so they're not getting all their nutritional needs. And I think the microbiome is something that's going to be very important to look at and to study, and I think Dr. Bach is going to talk about that more. The thing that's interesting about probiotics, I used them mostly in the study to prevent antibiotic-induced diarrhea. But probiotics have actually found to have a lot of potential in immune modulation and may have some neurochemical improvements in children that hasn't been studied yet. Okay. I'm done. And so I got a 0. It's like I've been scored a 0. Dr. Seelig mentioned this about vitamin D. I am a big believer in vitamin D, and there's been a lot of data coming out supporting this in PANDAS and supporting it in infections. And actually, there was a study in adults that had recurrent strep, and those that had recurrent strep had lower vitamin D levels. Vitamin D has a lot of properties and has neurochemical properties and immune modulating properties. Just to kind of give you a hint on dosing, usually if they're less than 6, I do 1,000 IUs, and if they're over 6, I usually use 2,000 IUs. And I won't go over the case presentation. And just in conclusion, I think antibiotics have been shown to be helpful in PANDAS, and I think they may have other properties like immune modulation and neurochemical properties that may be of interest to study to see if there's some common pathway that may make for better psychotherapeutic medications for these children. Thank you.
This slide is not a typo. Maybe I should have given this earlier. And I'm a bit tongue-in-cheek about this slide because I am constantly asked this question, right? So I thought that actually that it would be helpful to actually title a talk this and go and make the case because I think all of us share a common goal in wanting to help kids with this. I wanted to help families with this, but I don't want to. I want to be convinced by the evidence for something, right? I want to be convinced by the evidence that this exists, and not convinced for other reasons, and convinced that we can help kids by identifying this and that it's different from OCD because. I think it's wonderful today how much we're talking about OCD and tics and Tourette's. But I really want to go on a record as saying, not that anyone else here is saying this, I don't believe that all OCD is caused by inflammatory disorders or that all OCD is PANDAS or that all tics and Tourette is PANDAS related. And I'll talk a little bit about this as we go on. And the difficulty really comes down to how we differentiate between these populations and how well we do that. And so I think that is kind of part and parcel at times as to why very frequently I'm asked this question both by physicians, by parents, and it's amazing how differently people come down on either side of this question. So just to run over the numbers that we're discussing right now, so OCD is 2 to 3% of the population worldwide, right? Both in kids and adults. Tourette is about 1 to 2% of the population, and a transient tic disorder is amazingly, the estimates now are that it's anywhere from 10 to 15% of kids, and the vast majority of those tics go away as they get older. So these are very, very prevalent conditions in society. And the lifetime prevalence of streptococcal infections is really unknown, but it's probably ubiquitous, right? The vast, vast majority of kids, the vast majority of us have had a strep infection at some point in our life. And so if we contrast that now with what we know about the genetics for these disorders and the genes that have been discovered that are associated with OCD or with Tourette syndrome, there are so few. So there's not a single genetic finding right now for obsessive-compulsive disorder in kids or adults. There's not a single genetic sort of locus that has really been agreed upon to be associated with, and then that has also been replicated, that has been associated with OCD. There are 2 for Tourette syndrome, both found by Matt State, slit track, and then the histamine decarboxylase. They maybe explain close to 1% of all the cases of Tourette syndrome. So they are a very, very rare sort of subset of folks with Tourette. And then in chronic tic disorders, there's really not a known genetic cause. So we can't do any genetic testing to help us differentiate, again, between who's got PANS, PANDAS, and who's got OCD or Tourette's or tic disorders. And for biomarkers, then going back to the PANDAS and PANS side, again, we've talked a lot about this today, and you've heard from Dr. Benpazzi and Dr. Cunningham, so I won't belabor those things today, but we have few that really, I think right now, do a good job of discriminating kids who have had a recent strep infection from kids who have PANS or PANDAS. We need to do a lot more work, and we need to include a lot more kids in these studies to really have enough statistical power to be assured that these tests can actually differentiate or discriminate between these populations. So if the diagnosis is made clinically, then basically due to the presence of all of the different PANS and PANDAS diagnostic criteria that we've gone over today. So we are using the clinical symptoms and the natural history of a disorder to argue that it has a different etiology, it has a different basis than the rest of these disorders. And that is okay. It's been done obviously before, but the question is then how we progress with that to actually close the loop on this in the next 5 years, to really sort of say to people, yes, this was our hypothesis, and now we found a significant amount of information that makes this case. And so the null hypothesis here would really be that these disorders really are not etiologically unique, that OCD, tics, TS, all of these things, essentially, there is no association with a strep infection, and there's no real association with inflammation. Maybe those 2 things could be made, those arguments can be made separately. But again, this is when someone is making the case that this disorder doesn't exist, this is frequently the argument that I hear, that these things really have no mechanistic relationship to them whatsoever. And so I just want to run over then, I guess, the summary so far of sort of how we make the case, how we decide about these things. And it's unique to be presenting at a conference like this because the majority of things that I'm going to talk about next have already been presented on today. So I'll do it very quickly, and we'll save time for the question and answer session at the end here. But again, what I think the challenge is that we are looking at these disorders which are highly comorbid and then also share a frequency with an infection that is ubiquitous. And we need to find some tools, and I think that we need to really define them soon, so that we can end sort of this, is it there, is it not there? Because really, these conferences are wonderful, but I see only PANDAS patients now, and I think things have changed in the last 4 to 5 years as far as pediatrician sort of receptiveness to the disorder or neurologist receptiveness, but I really don't think the needle has moved all that much, to be honest. I mean, there is some, but it's not in the, I think, with the rapidity that we would like. So the historical support, from Sydenham's Korea, I think is solid and provides evidence, again, that this is a unique entity. And then the clinical experience also. So when I am very convinced that a child has PANDAS, I have seen the progression of symptoms from not being there to incredibly disabling. I mean, disabling OCD, that happens with a speed, a rapidity that I usually don't see outside of a kid that I think I'm evaluating for PANDAS. So I've seen, I've treated a lot of kids with obsessive-compulsive disorder and tic disorders, but there is really something like a lightning strike in most kids who have PANDAS. And it gains speed very quickly. And again, that could be a natural, normal variant of obsessive-compulsive disorder. It doesn't have to be a unique entity, but it feels different. And the clinical course of this disorder feels different from when you're treating kids with sort of, not garden variety, but sort of non-PANDAS OCD, if you will. So, and I think that, I won't belabor, Dr. Benos gave a great talk today, but I think that the epidemiological support is starting to emerge far more so from the population-based studies than what we were able to do in the United States from insurance and healthcare-based studies. It really takes studies on the level of an epidemiological and a population-based study, I think, to draw out these associations in a convincing way. And then, for treatment support, we have, Tanya just ran over some great talks about studies about that antibiotics in clinical trials show some support that they treat OCD symptoms. Certainly in clinic, I am convinced that I see an antibiotic effect in the kids that I treat for PANDAS with antibiotics. Not in everybody, and I couldn't tell you who is going to respond or who's not going to respond ahead of time, but some do. Oh, am I about to get a zero? How am I doing? That's what you're getting out there. Oh. Really? Yeah, it's like, I feel like I'm being judged at the Olympics here. So what I think some of the very interesting new information that's coming out from Jenny Frankovich and Stanford is that judicious use of steroids, anti-inflammatories, early in the course of illness really can cut down on the length of a flare, the length of symptoms. And again, so we haven't taken a population of kids who have non-PANDAS OCD and see if steroids make them better, because we'd want to understand that too. Is it specific for PANDAS or is it generalized to OCD? Excuse me. But again, we're starting to see the outlines of maybe a different treatment response in this population, which again, I think argues for potentially that it's a different starting point, it's a different etiology. And then translational support, and what I mean by that is looking at these different populations and looking to see are there clinical mechanisms that we can find that are different between the two, has come from Harry Shigani's work, looking again at the activation of immune cells in the brains of kids with PANDAS and showing that it seems like they're heightened compared to, again, because of the difficulty in doing these studies, this is compared to, I believe, adults with Tourette syndrome, but it seems like there is a significant elevation of this microglial signaling in kids with PANDAS compared to controls. And then I covered this morning, so I won't belabor it too much. But we're finding that maybe there are some other additional autoimmune antibodies along with what Dr. Cunningham and Dr. Van Pazzi have found that makes sense as far as the etiology of tic disorders and OCD, that if we find reactivity or damage of this specific type of neuron in this area of the brain, we've seen that before, and we've seen that before in tic disorders. So to me, it's it makes sense that we're not completely reinventing the wheel here. We know in some sense, what these neurons do, and an immune reaction against these, I think would make sense for the pathology that we're seeing in these kids. So converging lines of evidence really support, I believe, that a subset of patients display obviously an acute onset of OCD or tics, that the therapeutic response to antibiotics and anti-inflammatory or immune response is unique, potentially, or different. Although few controlled, aside from the IVIG study, there have been few other controlled studies of either non-steroidal anti-inflammatories or steroids in PANDAS. And then again, we are all looking for differences in autoimmunity to different brain proteins or structures in kids with PANDAS compared to controls. So what would the smoking gun be? What will it take to sort of end these conversations about is there not a disorder called PANDAS or PANS? Part of it would be really finding genetic tests for OCD or tic disorders, that wouldn't necessarily be in the PANDAS-PANS realm, but if we can just rule out or in, if you have those genes, maybe that would be quite helpful in sort of determining who has PANS or PANDAS. Identification, verification of autoimmune antibodies obviously would be a major smoking gun, really, and I think that we're getting there with Dr. Cunningham's work and Dr. Van Pazzi's work, but we need to sort of move that out into sort of wider-based studies to really to have a lot of confidence in those testings. And then significant divergence, I think, in treatment would be another thing that helps to define this population that really starts to end this sort of controversy about this disorder. Because, what I think right now when I'm thinking about this is that there's likely a genetic risk obviously for obsessive compulsive disorder and tics, and there are immune-related contributing factors to this, but that we may see as significant, what we're calling PANDAS in a lot of kids may be the unmasking or the expression bringing to the forefront your genetic risk for obsessive compulsive symptoms or disorders, right? So maybe you were 70 to 80% of the way there for the genes that you inherited for obsessive compulsive disorder, and what pushes you sort of over the finish line are some infections, some inflammatory reactions, something else that's sort of this two-hit hypothesis that you need both of these things to express these symptoms. And that may look like PANDAS clinically then, right? Those patients may respond to anti-inflammatories. It may be a relapsing remitting course. But then there also is likely a portion of this population that has more of an autoimmune antibody, an autoimmune encephalitic picture that will probably respond far more so to things like IVIG, anti-autoimmune therapies, those kind of things. And what I think about and what I would like to know, because right now I don't know that we can tell those two populations apart. Who's got more of the autoimmune encephalitis picture versus who's got more of the potential unmasking of obsessive compulsive genes or risk factors due to an infection or inflammation. I hope that basically, within the next 5 to 10 years, we'll figure something out in this direction, and we'll do so with imaging techniques and then with a deeper understanding of autoimmune antibodies. But I think that that's where we're at right now, and I think that the next steps in both treatment and research will hopefully drive this kind of controversy back out of. It will just be a discussion, right? It will just be a discussion like we've had medical discussions for years, and people will not be so, I think, defensive or upset about this. It really, to me, is, and I don't mean upset, I mean upset in this medical sense where I have conversations with physicians who seem like they're angry to talk about this sometimes. And I don't mean to put physicians down. I mean, I love doctors, obviously. But no, I don't want to put anybody down. But I do think that there's been this kind of balkanization of this disorder that, to me, I just don't understand. And I think that the way to move beyond this is that we will find some evidence, we'll find some things and move forward with this because we really have to. And with that, I will say thank you to everybody here and for the program itself. Also, one of the things that I really want to say thank you to is that we have some phenomenal anonymous donors who keep us alive. And because as a psychiatry clinic, we lose money on the vast majority of visits, and we are relying upon philanthropy to keep going. And we've been very, very fortunate due to the generosity of some funders who care deeply about this and will keep us going in the future, hopefully. So thank you all.